Hello, my name is Jordan Lee Slowick. Thank you all for joining me on this module. Today we're going to be talking about a topic that is very near and dear to my heart, malrotation and volvulus in neonates and pediatrics. Thank you for joining. There will be 5 learning outcomes in this module. The first learning outcome, identify the differences between normal intestinal anatomy versus a patient born with intestinal malrotation. Number 2, recognize the significance of a bilious emesis in a newborn or pediatric patient. Number 3, apply post-operative nursing knowledge to the care of the newborn or pediatric patient born with malrotation volvulus. 4, understand the impacts of short bowel syndrome and intestinal malrotation post-volvulus. 5, discuss the importance of patient advocacy and nursing intuition.
Let's first review intestinal anatomy. The small intestine is made up of 3 segments, which form a passage from your stomach to your large intestine. The opening between your stomach and the small intestine is known as the pylorus. The duodenum is the short section of the part of the small intestine that takes in semi-digested food from your stomach through the pylorus and continues the digestion process. The duodenum uses bile from your gallbladder, liver, and pancreas to help digest food. The jejunum is the middle section of the small intestine that carries food rapidly through with wave-like muscle contractions towards the ileum. The ileum is the last section and the longest part of your small intestine. The ileum is where most of the nutrients from your food are absorbed before emptying into the large intestine. The purpose of the large intestine is to absorb water, salts, and get rid of any products that are left over. What is mainly left is fiber, which is a plant material that takes a long time to digest. Additionally, there are dead skin cells that are shed from the lining of your intestine, salt, bile pigments, and water. In the large intestine, bacteria feed on this mixture. This helpful bacteria produce valuable vitamins that are absorbed into your blood, and they can also help digest fiber. The large intestine is made up of the following parts: the cecum, the colon, and then the colon is made up into the following parts: the ascending colon, the transverse colon, the descending colon, and the sigmoid colon. The rectum is the final section of the digestive tract. Leftover waste collects here and expands in the rectum until one feels the urge to empty the bowels. The bowel movement is then emptied through the anus. Intestinal malrotation typically affects both the small and large intestine. Sometimes only the small intestine or only the large intestine is affected. Most people don't know they have intestinal malrotation until they begin to experience complications. In utero, the digestive system begins as a straight tube. At 5 weeks gestation, the tube starts to develop into the esophagus, stomach, small intestine, and large intestine. During this time, the part of the digestive tract that will become the intestine moves out of the abdomen and into the umbilical cord. For most babies, as the intestine forms, it re-enters the abdomen, making 2 separate turns, and then lands in the typical position by 12 weeks gestation. If an error occurs at any time during this normal rotation process, it can cause the intestine to be positioned incorrectly within the abdomen. This is known as intestinal malrotation. How common is intestinal malrotation? The exact incidence of intestinal malrotation is unknown. Birth defect surveillance data indicates that symptomatic intestinal malrotation affects between 2 and 3 out of every 10,000 babies in the United States, or about 1 in 4,000 babies each year. However, there is a 40% chance of those affected by intestinal malrotation that they are diagnosed after age 1, meaning the rate of symptomatic intestinal malrotation is more like 1 in 2,300. Many sources state that there is some degree of intestinal malrotation that may affect as many as 1 in 500 people. This is based in a very small study from 1934 and does not indicate what percentage of participants experience symptoms or complications.
Volvulus. The unique position of the digestive system in intestinal malrotation allows the intestine to twist upon itself. This is known as a volvulus. Volvulus is a type of intestinal obstruction and is a dangerous complication of intestinal malrotation. A volvulus is a surgical emergency. Please remember this.
Let's talk about a key sign that a volvulus has occurred. A bilious emesis is reported in 80% of pediatric patients with a volvulus. Vomiting bile should be considered intestinal malrotation and volvulus until proven otherwise. Other signs and symptoms related to vomiting include vomiting undigested formula, breast milk, or food if older, projectile vomiting, large amounts of vomit. The parent may even state the baby threw up the whole feeding. The pictures you see are of a bilious emesis from the same patient. The patient's mother stated the emesis was projectile in nature. A 7-pound, 9-ounce baby who was 6 days old would projectile vomit 6 to 7 feet across the room. Picture A's emesis is neon yellow. You can see that the undigested bile salts are mixed with white formula, creating a yellow color. In picture B, the emesis is dark like ground kale. The bile salts had nothing to mix with, leading to the dark green color. Another sign that a volvulus has occurred would be changes in bowel movement. The patient may have absent or decreased bowel movements or sounds. The patient may also have painful bowel movements. If the patient is a baby, the baby may appear to be straining, grunting, breath holding from pain. When a baby breath holds, it is very scary. They can turn red or even blue. The patient may also have diarrhea, dark brown, black, or bloody stools, and the inability to pass gas. In the picture you will see a patient that was 7 days old with amber-colored urine. He was extremely dehydrated from his volvulus. And then in arrow B, you'll see that there's blood within the stool, and this stool was created by a glycerin suppository. Other signs and symptoms that a volvulus has occurred include abdominal distension, abdominal wall erythema, abdominal pain that can be consistent or intermittent, mild to severe, and can be often hard to distinguish in babies and young children. The child may also be refusing to eat or have a lack of appetite. They may be lethargic or fatigued. They may excessively cry or be inconsolable. Because fluid and nutrients are absorbed in the intestine, dehydration and electrolyte balances may occur very rapidly in a person whose intestines are blocked by a volvulus. You may also see dark urine, amber-colored urine, sunken fontanelles, sunken orbital sockets, as well as decreased urine output. You also may see signs of an infectious process like fever or elevated white blood cells.
So, why is a volvulus a medical emergency? A volvulus can restrict venous and arterial blood flow, which causes necrosis of the intestine. The intestines are a highly vascular organ. Once blood flow is cut off, death to the bowel will occur quickly if not emergently corrected. Once a volvulus has occurred, death to the bowel occurs in less than 2 hours. Volvulus can cause perforation of the intestine, leading to severe decompensation and sepsis. Volvulus is a surgical emergency. Please remember this. Refer to the picture to the right of the screen. This picture is of an infant with a significant portion of necrotic small intestine resulting from a midgut volvulus. Notice that the intestine is dark and lifeless. Healthy bowel should appear pink and well perfused.
How do we diagnose a patient with malrotation and volvulus? Patient presentation. The initial abdominal exam may be completely normal, luring the practitioner into dismissing the diagnosis, which unfortunately may lead to progressive bowel ischemia, hypovolemic shock, and possibly death. To diagnose intestinal malrotation with volvulus, an upper GI series, also known as a barium swallow, is most frequently ordered. It is about 95% accurate in diagnosing intestinal malrotation with volvulus. Other tests include a lower GI series, also known as a barium enema, a CT scan, or an ultrasound. In the picture, you'll see a patient who had intestinal malrotation with a volvulus, and you can see the corkscrew appearance of the duodenum. Treatment for intestinal malrotation and volvulus includes the LADS procedure. A LADS procedure does not place the intestine in the correct anatomical position. The goal of the LADS procedure is to untwist a volvulus and place the small and large intestine in a position that makes them less likely to twist in the future. An appendectomy is always conducted during the LADS procedure. Why do you think that would be? Let's talk about post-operative nursing care for a patient post-LADS procedure. First, we'd want to monitor the fluid status. Is the patient on fluids? Are they on TPN? How long have they been on fluids or TPN? And is those fluids going at an appropriate rate? Also, we would want to monitor fluid output.
We'd want to make sure that the baby is urinating, and we'd want to make sure that we're measuring diapers accurately. We'd also want to see if the baby is stooling. Also, all babies or patients post-LADS procedure will have an NG tube to decompress the belly. We want to make sure that we monitor the color and the output of that material. We also want to monitor the skin, making sure the incision site is clean, dry, and intact. In regards to bowel assessment, it takes a little bit for the belly to actually wake up. We want to make sure that we reassure our families and parents that this does take a little time, and that even though it's stressful that baby cannot eat for a few days, it is well worth the wait waiting for that belly to wake up. We also want to make sure that the patient has labs. We want to make sure that the electrolytes are getting back into balance. And lastly, we want to make sure we support our parents and the patient. This is a very stressful time for families, and they need all the support and love that we can give them. Complications of volvulus. Unfortunately, when neonates or children are not diagnosed quickly or accurately, necrosis of the bowel becomes a significant issue. The dead portions of the bowel are removed. Portions of the bowel that have had questionable perfusion status may require a second look surgical procedure. This is when the surgeon enters the abdomen 24 hours post initial surgery to determine if the bowels have pinked up. Hopefully, perfusion is restored and no additional bowel is to be removed. Other complications include fecal diversions such as ileostomy or coleostomy, short bowel syndrome, in which we're about to go into great detail in the next slide, adhesive small bowel obstructions. This is when scar tissue or adhesions block the intestine from functioning properly, sepsis, and sadly death. Let's talk about short bowel syndrome, also known as short gut syndrome. Short bowel syndrome is an unfortunate result of a volvulus. According to Dr. Caffardi with Johns Hopkins Medicine, a suggested definition for short bowel syndrome in pediatric patients is the requirement for intravenous nutritional and fluid supplementation in those with less than 25% of remaining small bowel than what is expected for gestational age. This condition results from the alteration of intestinal digestion and absorption that occurs after extensive bowel resection. It is a complex disorder with nutritional, metabolic, and infectious consequences. Bowel obstruction is a potential complication of short bowel syndrome. Although short bowel syndrome may rarely be a congenital condition, most pediatric patients with short bowel syndrome have undergone bowel resection for one of the following reasons. 1. A congenital anomaly such as omphalocele, gastroschisis, or intestinal atresia. Interestingly enough, omphaloceles and gastroschisis are forms of intestinal malrotation, which means the intestines are not in the normal anatomical position. Necrotizing enterocolitis associated with prematurity is also a cause of short bowel syndrome. Intestinal ischemia related to malrotation and volvulus, and Crohn's disease, which is unfortunately a common occurrence in pediatrics. Nursing considerations with short bowel syndrome include nutritional deficiencies, malabsorptive diarrhea, dehydration, vomiting, bloating, GERD, failure to thrive, drug toxicities, and sepsis. Management of short bowel syndrome. The institution of early and aggressive enteral therapy is the most important stimulus for intestinal adaptation, as well as the eventual discontinuation of parenteral therapy if possible. Aggressive resuscitation with fluids, parenteral nutrition, or both is often required the first week after intestinal resection. Hypersecretion is a common issue post 12 months resection. Treatment with H2 receptor blockers, or PPIs, are frequently prescribed. Teguglide, also known as Catex, is used to enhance GI absorption for children who are 1 year or older and are TPN dependent. Bacterial overgrowth in the proximal small bowel is another issue in neonates with short bowel syndrome. Antibiotic therapy include alternating flagyl with either kanamycin or oral gentamicin. Bowel resection causes malabsorption of bile acids. The increased load of bile acid on the colon increases the secretion of salt and water, causing diarrhea. Cholestyramine is used to bind bile salts with child suffering from persistent diarrhea. A diverting ileostomy can be used to prevent the stagnation of stool in patients with significant dysmotility. Small bowel transplants are used only if absolutely necessary in patients with associated severe advanced liver disease or those with major intestinal vascular problems. If the liver has been severely impacted, an isolated liver transplant may be indicated, only if bowel transplant is not required. What is parenteral nutrition? Total parenteral nutrition, also known as TPN, is a method of feeding that bypasses the gastrointestinal tract. TPN delivers a mixture of fluid, electrolytes, sugar, amino acids, vitamins, minerals, fats into an infant or child's central line, such as a port or a pig. TPN is extremely caustic to smaller veins and should never be given in anything other than a central line. The goal of parenteral nutrition is to correct or prevent malnutrition. Peripheral parenteral nutrition, also known as PPN, is usually used for less than 14 days. It can be delivered via any IV site with the thought process the larger the vein, the better. PPN has lower amounts of fluid and glucose than TPN. Additionally, PPN has lower osmolarity in order to be tolerated by smaller veins. Depending on the hospital, TPN orders are typically placed by registered dietitians or physicians. It is the nurse's responsibility to ensure that the correct paperwork has been filled out and placed by whatever time designated by the hospital's policy. TPN is mixed on-site or off-site by pharmacists and is typically hung during night shift. Let's talk more about important lab values to monitor with TPN and lipids. The following labs should be monitored biweekly, both in the initial phase or at the time of presentation for instability. Electrolytes, BUN, creatinine, calcium, magnesium, and phosphorus. A comprehensive metabolic panel, CBC, triglycerides, cholesterol should all be monitored weekly in the initial phase or at the time of presentation for instability. Lastly, folate, vitamin B12, vitamin E, copper, zinc should be monitored monthly in both the initial phase or at the time of presentation for instability. A significant portion of infants who depend upon parenteral nutrition because of intestinal failure develop liver disease. Intestinal failure-associated liver disease, also known as IFALD, is a disorder that is particularly common among infants with a history of prematurity and/or bowel resection. Liver failure is a major cause of morbidity and mortality in this patient population. The pathogenesis of IFALD is multifactorial and includes gastrointestinal disease-related, parenteral nutrition-related, and systemic-related factors. Alteration of bile acid circulation, gut microbiome, and intestinal permeability seem to be the main mechanisms. Patients forced to a total oral fasting regimen are at greater risk. Parenteral nutrition overfeeding and/or using soybean-based lipid emulsions may also be contributing factors. Prevention and treatment are based on avoiding and promptly treating all of the risk factors mentioned.
A typical presentation in older children or adults may include acute abdominal pain, intermittent bilious emesis, chronic and vague abdominal discomfort, nausea, diarrhea, malabsorption syndrome, and other less common characteristics would include bloating, constipation, GI bleeds, feeding intolerance, and failure to thrive.
I'm now going to read you two stories about malrotation of volvulus. The two stories are actual patients, and I'm not going to lie, they're going to be hard to listen to. I've actually recorded this multiple times and had to start over multiple times because I cry. But I'm going to do my best to read Nathan's story. When my son Nathan was born, he couldn't keep anything down. He would violently spit up formula and was diagnosed with reflux. Every time he spit up, it was yellow and smelled like vomit. The pediatrician never gave us a referral to a GI or any other kind of specialist. Looking back, I wish I would have known how to request one. A newborn with such violent reaction to breast milk and formula should have warranted a GI evaluation. As Nathan got older, the vomit did ease a little bit, but it never fully went away. About twice a month, I would take Nathan to see his pediatrician, but I was always told that he had a stomach virus. I was the stay-at-home mom for the first 7 months of Nathan's life, but due to financial reasons, it ended up working better for me to go back to work when my husband stayed home with Nathan. In between the frequent stomach viruses, Nathan seemed like a perfectly happy and healthy baby. The morning of December 30th, as I was getting ready to leave the house for work, I picked up Nathan and he vomited all over me. As usual, his vomit was bright yellow. I was already running late, so I told my husband not to bother taking Nathan to the pediatrician unless he got worse. I knew they would say that it was just another stomach virus. While I was at work, my husband called to say that he was taking Nathan to an urgent care. Nathan had continued to vomit and his temperature had dropped to 96 degrees. I left work and met him at the office where I found my sweet baby moaning in pain. I immediately picked up Nathan and tried to nurse him. After he drank a few gulps of milk, I smelled something terrible. I thought, oh my gosh, this can't be coming from Nathan. I brought Nathan and the diaper bag to the bathroom and back, leaving my husband in the waiting room. When I opened Nathan's diaper, I was shocked to find his little body pulsating out diarrhea and blood. The blood was brownish red and it looked similar to jam or currant jelly. I knew something was seriously wrong. I ran out of the bathroom to the nurse's station, screaming and begging someone to help save my baby. When I looked at Nathan, he was just rolling his neck and moaning in pain. I carried Nathan to the exam room and laid him on the table. The room was filled with doctors and nurses very quickly. Nathan suddenly stopped moaning and I started screaming. The doctors hadn't realized I was still in the room and quickly moved me to a separate room away from Nathan. After being moved, I was finally able to ask the nurse to get my husband, who was still in the waiting room on the front, unaware of what happened. After what felt like an eternity, an ambulance arrived to take Nathan to the nearest hospital room, where he was diagnosed with intestinal malrotation and volvulus. They spent the next few hours calling different pediatric hospitals, trying to find one that would take Nathan and perform the life-saving LADS procedure that he desperately needed. Every hospital in the area said no. They didn't have any beds available. Finally, Lurie Children's Hospital in Chicago said that they could take him. It was December and the weather was horrible. The helicopter took 2 hours longer than expected just to pick up Nathan for transport. When they finally arrived, we had to wait for longer for the weather to clear. Because of the storm, the helicopter wasn't able to land. It landed nearby, and they planned to go the last 15 minutes by ambulance. I rode in the car to Chicago with my in-laws, mother, and husband. I was in complete shock over what was happening and kept passing out. As we were driving, I woke up very suddenly at 10:05, feeling panic and asking what hospital we were going to because I couldn't remember. I called Lurie and explained that I was looking for Nathan. I told them I was supposed to have gotten a call when they went to surgery, but I hadn't heard anything yet. I was put on hold and was never reconnected to the operator. The drive to Lurie should have taken 2.5 hours. Despite the weather, we rushed and arrived in less than 2 hours. I immediately ran to the hospital room with my mom and husband right behind me to ask the front desk where Nathan was. They said he was in room 1641 and we took off running to find him. When we got to the 16th floor, the nurses stopped us and said we needed to go to the conference room. I didn't knock when I walked into the conference room, and I remember how shocked the doctors looked. They asked me to sit down, but I couldn't. I just kept yelling, "Where is he and why aren't you in surgery with Nathan?" The doctor said, "I'm sorry he didn't make it." His heart stopped in the ambulance and he didn't make it. Nathan had died at 10:05 p.m., the exact same time I'd woken up in the car. The amount of time from his first vomit that morning to the moment he died was less than 13 hours. When I heard the news, I fell on the ground screaming. My husband eventually helped me up, and we were led to Nathan's hospital bed. He had been dressed in clean footy pajamas, and his breathing tubes were still in place. I'm now going to share with you all Oakley's story. Oakley's story, written by his mother. When my son Oakley was born, he looked and acted perfectly healthy at first. As I was holding Oakley, just staring at this beautiful boy I had delivered, he forcefully spit up yellow-tinged fluid. I didn't think about the color of the spit up, but how startled I was by how forceful it was. My husband and I told the delivery nurse, who said it was just amniotic fluid. We asked several more people if Oakley's spit up seemed unusual, but they all reiterated it was fine. Although everyone kept telling us it was normal, we were still concerned. I delivered Oakley at 4:16 p.m. and was transferred to our postpartum room right before nurses changed shift at 6:30. The nurse who was finishing up her shift when we arrived took one look at Oakley's yellow-tinged baby blanket and told us not to panic, but she was going to bring this to the attention of Oakley's doctor. The pediatrician caring for Oakley assured the nurse that Oakley was fine. She knew something wasn't right, so she went around the pediatrician to the NICU doctor. On nothing other than a gut feeling, she asked the NICU doctor to please evaluate Oakley. That nurse, Jen Coleman, was Oakley's nurse for only 30 minutes. In those 30 minutes, she saved my baby's life. The NICU doctor felt that Oakley's spit up was concerning enough to perform an upper GI series. The color of the spit up had begun to change from yellow tinged to bright yellow and then green. I didn't really understand what was going on. I was a nurse myself in the critical care setting, but when it came to my own baby being sick, everything I knew seemed to leave my mind. I was in shock and denial. While Oakley was taken to the GI lab, I Googled, why would a newborn spit up green? I scanned words such as volvulus and surgery, and then immediately shut my phone and told myself Oakley would be fine. Around 9 a.m., they told me that Oakley's upper GI series showed a narrowing of his intestine. They also told me that Oakley was in the NICU being prepped to be transferred to a pediatric hospital where he would likely need surgery. As soon as the doctor told me Oakley would be transferred to surgery, I burst into tears. I didn't understand what malrotation or volvulus was. It was like Charlie Brown voice. People would talk and I just heard noise. The only thing I could think about was my not even 1 day old baby, 7 pounds, 2 ounce baby needing surgery. After, after that, survival mode took over. The nurses on the maternity unit asked what they could do for me, and I told them I needed to leave. I hadn't been discharged yet, but I told them I was going with my baby and I needed them to make it happen. They drew my postpartum blood work, and I got dressed and packed my bags. They reviewed discharge instructions with me as I walked down the halls to the NICU. An ambulance arrived to transport us to Children's Hospital of Philly. After a 40-minute ride to CHOP, we found ourselves kissing our newborn baby goodbye as they carried him into surgery. My world felt like it stopped during the hour he was in the operating room. All I can remember is praying that my sweet baby boy would be okay. Luckily, his obstruction was caught early and no damage was done to his intestine. The surgeon performed a LADS procedure to prevent future twisting. A week later, we were able to take our sweet baby boy home. As a nurse, I wanted to know all the facts. When the surgeon explained intestinal malrotation and LADS procedure, I asked if there was anything we needed to worry about in the future. The surgeon said that there was a very small chance of a recurrent volvulus after LADS, but that was extremely unlikely. Oakley was essentially fixed. Oakley was healthy at first, but a month after surgery, he started to spit up yellow again. It wasn't forceful, and Oakley didn't seem bothered by it. Panicked, I took him to the surgeon the next day. The surgeon looked at the spit up, looked at Oakley, and told me everything was fine. He thought I was just worried because he had mentioned a small chance of a recurrent volvulus. I asked if he wanted to do any tests to be sure he wasn't in a volvulus, and he said it wasn't necessary. Over the next 3 months, Oakley got worse. It happened so gradually that we didn't realize how bad it had gotten. He began to spit up yellow frequently. He was fussy, he cried, and he had trouble staying asleep. Eventually, he started to have what we called episodes. He'd become very upset, then forcefully spit up large amounts of yellow fluid. Because the surgeon had told us it wasn't a surgical problem, I started bringing Oakley to the pediatrician. We went so often I felt the pediatrician thought I was crazy. Oakley was diagnosed with an array of normal baby things: reflux, colic, stomach virus. We wanted to believe the doctors. We wanted to believe those things, but deep down we knew something wasn't right. When Oakley was 4 months old, we got in touch with an amazing pediatric GI doc. The day of our first appointment, Oakley was in a good mood, and I was worried the new GI wouldn't believe there was a problem. Instead, she helped us put a plan in place to figure out what was going on with Oakley. I cried on my drive home because it felt like I finally had someone in my corner. The day after the appointment, Oakley began to projectile vomit large amounts of yellow spit up. I called the GI and she instructed me to take Oakley to CHOP's emergency department for upper GI series. She wanted upper GI done during one of Oakley's episodes. Oakley continued to forcefully vomit yellow fluid the entire 60-minute ride to CHOP. In spite of the vomit, his stomach remained soft and he was smiling. As we waited in the emergency room, Oakley spit up green for the first time since the volvulus on the day he was born. During Oakley's upper GI series, I stood in the room and watched as the contrast refused to move through his digestive system. At that moment, my stomach dropped. I knew this meant my poor baby had been suffering for months and I was going to need surgery. We soon found ourselves in that familiar OR hallway, once again kissing our baby goodbye as they carried him to surgery. After the second longest hour of my life, the surgeon came to talk to us once again. He had said that scar tissue had undone the first lad's procedure and that Oakley had likely been having intermittent bowel obstructions and pain for the past 3 months. Somehow, Oakley had managed to escape any permanent damage to his intestine. After 3 days, we were able to take our precious baby home once again. After his second surgery, Oakley was a new baby. He was calm and happy. His appetite doubled overnight. Oakley was followed by a pediatric GI for about a year to help deal with reflux and constipation. He is now a healthy toddler who no longer needs any specialist or medications. It is now time for the reflective journaling portion of this module. I am sure you have much to reflect about after hearing the stories of baby Nathan and baby Oakley. The reflective journal must be between 250 and 500 words. As you end your nursing school journey, I want to challenge you with the following questions. How did the stories of baby Nathan and baby Oakley impact you? In what ways was Nurse Jen an advocate for her patient? As a future nurse, how will you respond to your nursing intuition? Question 1. Short bowel syndrome in pediatric patients is the requirement for intravenous nutritional and fluid supplementation in those with less than blank of remaining small bowel than what is expected for gestational age. A. 75%, B. 25%, C. 50%, or D. 15%. Question 2. Why is the medication cholestyramine used in patients post-Volvulus diagnosed with short bowel syndrome? A. To decrease gastric acid secretion. B. To enhance absorption of the gastrointestinal tract. C. To bind bile salts in a patient suffering from persistent diarrhea. Or D. Pain management. Question 3. Which of the following portions of the bowel make up the small intestine? A. Jejunum. B. Ileum. C. Cecum. D. Both A and C. Or E. Both A and B. Which of the following is or are a form or forms of intestinal malrotation? A. Gastroschisis. B. Crohn's disease. C. Omphalocele. D. Both A and B. Or E. Both A and C. Which of the following neonatal and pediatric gastrointestinal complaints would require an emergent surgical evaluation? A. A 21-day-old with frequent episodes of straining and pain upon stooling. B. A 2-day-old who has failed to pass meconium. C. A 7-day-old with a bilious emesis. Or D. A 2-year-old with occult blood in stool. Question 6. What is the main goal of parenteral nutrition? A. To prevent malnutrition. B. To enhance liver function. C. To correct malnutrition. D. To minimize assault to the pancreas. E. Both A and B. F. Both A and C. Or G. Both B and D. Peripheral parenteral nutrition is typically used blank in infants and or children. A. For less than 7 days. B. For less than 21 days. C. For less than 14 days. Or D. For less than 10 days. This teaching project is dedicated to my son, Pierce Andrew Slowett. Pierce is almost 2 years old and is the brightest, kindest, sweetest little soul around. He is so brave, and we're so proud of all that he overcame with his Malrotation and Volvulus. I also want to give a special thanks to several doctors that without them, Pierce would not be here today. A special thanks to Dr. David Miller. Dr. Miller passed away unexpectedly recently, and we miss him dearly, and we think of him daily. Dr. Ross Morgan, who has since moved from the Orlando area, but we remember him frequently and keep up with him on Facebook. He is such a wonderful man. Our pediatrician, Dr. Pam Trout, who is truly one of the most fantastic doctors and individuals out there. We're just so grateful for you, Dr. Pam. And lastly, and definitely not least, Jesus Christ. Thank you so much for saving our son and healing his sweet body. For more information on malrotation and volvulus, please refer to the Intestinal Malrotation Foundation, which is www.intestinalmalrotation.com/information.